Now we are going to switch to English with Eduardo, who is going to review issues on new devices, new technologies, and hybrid procedures. Please, Eduardo.
Good morning to all. Thanks for the kind invitation. It's a true pleasure to be here, and congratulations for the new facilities. Quite outstanding. It reminds me of my fellowship in the Cleveland Clinic, so state-of-the-art facilities. Congratulations. So talking about new devices, new technologies, and hybrid procedures. So this is a lot to cover in 15 minutes. So I will try to be brief, and I will start with the new devices. And this is a very old slide. I think I'm probably exaggerating. I'm not sure if I used this slide back in 2010, but at least 2012, more or less. And what I'm going to show you next are the devices that were shown during TCT, CRF, LAA meetings, and you will see that nothing has changed much. So in terms of concept, the devices are pretty much the same as we had 8-9 years ago. So I will start with designs based on umbrella. This is the Lember occluder device. This is now available on the Portuguese and Spanish market. So it has the disc, and it has a lobe, which is more a set of anchors that are covered by a tissue that has pores and allows a very proximal implant. So the positioning of this device is very proximal, or even outside the LAA. So you can start to release the anchors, and once they are released, you can push the device into the LAA. It can press it. So even if you have a very, very short LAA anatomy, you are allowed to implant this device. And another interesting feature is that they have two sets of devices. So the one that you see on the right, on the upper part, is the conventional device, and in the lower part, it's a small lobe, small anchors with an oversized disc. So if you have two lobes, you can decide to implant the anchors in a small lobe, and then you have a very large disc that will cover the entrance of the LAA. And this is already available on our markers. This is the CLA. It's another device that it's conceived to promote an implantation very, very proximal. So it seems like an ASD device closure. The disc and the lobe are very close to each other. The lobe also has a tissue covering it, and the idea is to allow the manipulation of the device in a very, very proximal position. Then you have the cardia, which is also an umbrella design. There's a greater separation between the lobe and the disc. You can see there's a lot of space between the metallic parts of the device, so a lot of room for leaks. And to try to compensate this, they have a much thicker tissue covering the disc that it's outside. Then going for bold design, for more or less like the Watchman concept. This is the wave crest. So this is now has trials comparing against Watchman. It also has a CE mark. As I don't think it's available in Spain. In Portugal, it's not available for sure. And it allows, the concept of the device is to allow an occlusion without the use of echo. So you can implant a device, it occludes immediately the LAA, it has a tissue that doesn't have any porous. You can, once you have the device in place and it's not released, you can inject contrast, and you can see if you have complete occlusion of the LAA. And if you have good positioning and you have excluded leaks, you can then release the device. Then another device, which is the Occlutech, which has been around for many years. It has a small clinical study. Now it will have a new version with more anchors and improved tissue. And for something completely different, completely non-metallic design, allows an immediate sealing. This is the Prolipsis, which is a new version of the Sideris device, which was also called the immediate release patch, which was initially conceived for AST closure. It's a balloon that you can inflate within the LAA. Part of it can then be absorbed later on. It disappears. And you look at this and you can imagine that this might be the future because it's non-metallic. It adapts to many of the anatomies. It's non-traumatic, but somehow this has been around for almost 10 years and it doesn't have a CE mark yet. And then you have devices based on epicardial access. The Lariat, which also has been around as some clinical evidence. It's a mixture of epicardial and endovascular access. And then the Aegis, which is solo epicardial access. And finally, the minimally invasive surgery devices, which the AtriClip is the one that has been around for more years. And these type of devices, which are used by surgeons, I believe they are really a strong competitor to our field. And because they are not endovascular devices, these patients can really implant a device, and they don't have to be exposed to any antiplatelet or anticoagulation therapy on the first weeks or the first months. So this is very, very competitive. So now when I have patients that have complete contraindication for these types of therapies, I ask my colleagues on the surgical department to do this type of intervention. You see it's very 3 small incisions and the patient is released home the next day. So this is really a serious competition compared with what we do. So moving towards new technologies. Imaging will be the topic of the next session, so I will not talk much about this, but let me just say that ICE and rotational angio probably will be 2 strategies that will give us a true alternative to performing transesophageal echo during the procedure. This has been a major limitation of resources when we perform LAA. Many times we don't have access to anesthesiology, and the use of these 2 techniques, especially 3D ICE, I think will help us to move forward and to simplify the procedure. The other thing is angio-CT. I believe more and more centers are doing angio-CT prior to the procedure. I think it's a good way to truly appreciate the anatomy in a better way than a transesophageal echo, even when the echo is 3D. And even if you have a very difficult anatomy, you can use, for instance, 3D printing, and you can use several devices up front and try to decide what is the best strategy. Where is the best site to puncture the septum? What is the best sizing or model of device to use? So moving forward for hybrid procedure, combined procedure. So you can actually see that many publications, and you can see in many case reports about combining patients with percutaneous procedures of many natures. This is a summing up. I would say that probably the last 3 of them are, you have very strong arguments to join both of these procedures together, because these are transeptal techniques. So this is you are already on the left atrium. You already have a large sheath on the left atrium. So if the patient has a high Schatzvask, why not close the appendage? It's more or less the concept of a surgeon doing a surgery for something else, and then the patient has atrial fibrillation. Why not close the appendage? So the concept is more or less the same. So let me just say that for coronary intervention, I think this would make some sense a few years ago. But now that we have the results of Pioneer and Redual PCI, and stents are much, much better, I don't think this will have a strong argument to join complex angioplasty with LAA occlusion. For septal defect occlusion, it might be the case for a niche of patients that they have ASDs, largest ASDs, they have atrial fibrillation, so I'm talking about older patients that sometimes are referred to our cath lab. And atrial fibrillation ablation, there's a lot of publications, case reports. Dr. Ignacio Garcia also has published a nice report on with a nice experience with this technique. there's a lot of good arguments to join these techniques together. There's the residual risk after performing atrial ablation of stroke. Also, when you ablate the LAA, you may get the patient in sinus rhythm, but you lose contractility of the left appendage because it's isolated from the rest of the atrium. So there's a good argument to perform both procedures at the same time, and except for cryoablation, which there's a sign that you might have some additional risk of performing both procedures at the same time together. When you use other techniques, it seems quite safe. So saying that, I will focus on two topics, on TAVI and mitral intervention. So joining TAVI cases with LAA occlusion is something that we are doing since 2014, and there's a strong case for this. So more or less 1/3 of the patients that are referred for TAVI already have chronic AFib. So this is a large burden of atrial fibrillation in these patients. And on top of that, you can have new onset of atrial fibrillation from 10% to 30% after the implantation of TAVI. And this is truly a marker of bad prognosis. So these patients that already have AFib or develop AFib, they die more frequently, they bleed more frequently, they have complications, so generally speaking, more frequently. So they are frail, and they deserved a different approach. And the guidelines towards antithrombotic and anticoagulation therapy after TAVI are quite confusing if we see the scenario between different scientific societies. And when you have TAVI with atrial fibrillation, which can be from 1/3 to half of the patients, it's not clear what you should do, if you can just switch to anticoagulation, or if you have to combine some form of anticoagulation with antiplatelet therapy. So this is one algorithm that was proposed in 2015. These are not guidelines, it's just a proposal. And you actually can see that LAA occlusion already has a place here. So when you have a high Has-Bled, or you think that the patient has some kind of risk for being exposed chronically to oral anticoagulation, then you can think of LAA occlusion in the setting of atrial fibrillation. And this is one case that we performed. It's a patient with clear indication for TAVI based on this risk, on the score risk on age. And she also had a very risk of bleeding, chronic anemia with many transfusions over time. And we performed the CT angio for the TAVI, also for the LAA. You can easily appreciate here that you can have a view on the CT scan which is very similar to the views that you have on the angio, so you can predict what type of device you're going to use. The measures that you get on angio are quite the same, good correlation with TEE. And during the case, we didn't use TE, so we have these images from TE prior to the exam, the angio CT. So we performed first the TAVI, implanted an Edwards valve, then we made sure that everything was okay with the valve, and in that time, under full anticoagulation, we moved forward for the LAA occlusion. And actually, you can see there three things. So the Edwards valve, the SL1 sheath crossing the septum, and then you have the ICE probe on the right atria. And then advancing the catheter and the ICE probe to the left, we did the angio, implanted the Watchman device, did the pull test, the tuck test, sorry, and then release it, okay? And very simple. So we already talked about one feasibility trial that uses Amulet. This is another trial which was promoted by Fausto Pinto, which is my chairman, and Windecker. This is using Watchman, and initially was using Lotus. And now we are in a way of changing the protocol and accepting other valves into this protocol. And there's another one across the Atlantic, which is promoted by Martin Leon and Samir Kapadia, and uses also Watchman device and any TAVI TAVI device for patients with atrial fibrillation. But the competition is very strong. So these are feasibility tests. They are taking very long to include patients, and pharma trials are moving forward. And we are having a lot of trials in patients with indication to oral anticoagulation, meaning atrial fibrillation, that they are testing DAPT, low-dose NOACs with monotherapy of antiaggregation. So if we have a strong evidence of these trials before we have evidence of our trials, I think this field may be lost. The other thing is mitral intervention. In here, MitraClip, for now, it's dominating this field. And the concept, it's a little bit the same. So these are also very fragile patients with bleeding risk. They many times are not candidates for conventional surgery. And on top of that, you are already across the septum with a very, very large sheath. So much of the risk, it's already undertaken by the transeptal puncture for the MitraClip implantation. And in this setting, these patients have more prevalence of atrial fibrillation than even in TAVI. So you can see here that they have from 30% up to 70% of chronic atrial fibrillation when they are referred for this technique. And the concept is more or less the concept of surgery. So you see here, this is the indication for closing the LAA when the patient is submitted to conventional surgery. So if you have access to the LAA, it's recommended to close it. And recently we had the results from Laos 3 showing that they had a nice reduction of readmissions for systemic embolization with these techniques. So we're moving this concept towards the percutaneous field. And this is the first series that was published on neurointervention, which was extracted from the MITRA Swiss registry. So it's a pool of many centers, and they compared the interventions, combined intervention of LAA occlusion with MitraClip in 25 patients, and they compared with 25 patients with standalone MitraClip. Of course, they had a longer procedural time, longer radiation time, but other than that, in terms of success rate and other complications, it was quite comparable. So this was our experience. We published our small series last year. So we do the transeptal thinking on the MitraClip. That's our priority. After performing the puncture, we go straight to the appendage. We close the appendage because we use a smaller sheath to do this. And after closing the appendage, then we move forward with a larger sheath for the MitraClip, and then we do the procedure, and we close the access with the PERC close. So this is not mainstream. This is not directly recommended by guidelines, but these are areas that might be interesting to push forward LAA occlusion. Many thanks.
Thank you so much, Eduardo.